Today we're gonna start with usually the ventricle that is being left at the last. We'll start with the ventricle that to me is the most important. And as we profile patients, perhaps the ventricle that really requires the most attention as we intend our transitions, whether it's replacement, recovery, or sometimes as well patients that will not be able to be replaced or recovered to have a good transition to palliation or hospice. I'll start with a case to exemplify an extreme case, of course, of right heart shock on a patient in which transitions become difficult. So it's a 50-year-old male with heart failure and reduced ejection fraction, secondary to non-ischemic cardiomyopathy. And again, these big semantic qualifiers really need to be understood further. And in this particular case, he has dilated cardiomyopathy, conduction disease, and arrhythmias, ventricular arrhythmias, that has gone through the whole process of clinical guideline-based medical care, device therapy, as you can see with CRT. But when we look at these patients closely with what we call sort of deep phenoprofiling with advanced imaging, you can see in the MRI that truly the ventricle that is affected is the right side of the heart, completely dilated with a lot of signs of fibrosis. And the fact that the EF is 40% is basically because the septum is completely taken. And again, this is an important concept because, again, we try to englobe patients in HFrEF or HFpEF, but in this particular case, I think advanced imaging shed a lot of light in trying to find the diagnosis of this patient. Again, this patient ended up having multiple hospitalizations, as you can see in this very poor quality echo. You cannot even see the right side of the heart since it's so dilated and much bigger than the left in this four-chamber view. And the hemodynamics really support a completely right-sided failure issue associated with low output state. Again, very high RA pressures, very poor pulsatility in the pulmonary artery, and that inability to feel from the right side of the heart to the left side of the heart with very low wedge and translated into very low PA saturation, cardiac index. So this case exemplifies, low output state, transition, early stage of shock associated with right-sided failure. Again, conduction disease, arrhythmias, and again, from our perspective and just connecting that talk from yesterday, we are extremely invested in trying to document hemodynamics. And in this particular case, since there was a lot of arrhythmias on this patient, it was actually difficult to even leave the PA catheter inside, put it in because of a big right ventricle. And this is just to show that trajectory in this particular patient at this time. We didn't have, you can see the dates is 21. We didn't have truly ambulatory platforms that will not be ECMO. And in this particular case, we decided to bridge this patient to transplantation on an inotrope stain in the hospital with close monitoring. And in this particular case, we decided to actually put an implantable PA monitor to sort of create a surrogate of filling pressures from the right side predominantly. And that was the way that we actually monitored him towards successful transplant. But again, it's an extreme sort of case that exemplifies how the right ventricle really needs to be looked at it differently. We talked about this yesterday, IMI shock, heart failure shock, but I will add another semantic there, which will be IMI right ventricular shock or heart failure right ventricular shock. These patients behave very differently. You will see that there's a lot of gaps in what we understand from RV shock, and the majority of the things that we learn from RV shock in this particular cohort are from different diseases, acute PE, an RCA STEMI, and we haven't really created a good pathway for heart failure RV shock. However, the interest is there. Of course, the pulmonary hypertension literature and the collective literature from the heart failure space have brought us all together to start thinking about the right heart in a more dedicated way. I think there's a renewed interest in right side function, and of course, in this particular case, shock. And I will say perhaps the most recent article from New England Journal of Medicine really exemplifies the different pathophysiological mechanisms that have to do with what we do at the bedside, which is trying to understand whether this is an issue of volume, if this is an issue of afterload, if this is an issue of the muscle in itself, reduced inotropy, or if this is an issue of stiffening. Again, multiple mechanisms. I think end up again with RV dilation, with increasing the size of the right side of the heart. But again, most importantly, understanding that once you see right heart failure, these patients will not do well. And we have to come up with early interventions to help them transition. Again, from the early days of trying to profile the right heart in specific diseases that affect the left, like hypertrophic cardiomyopathy, we understand that the right ventricle is very, very sensitive to afterload. So high afterload states for the right side of the heart, like for example, pulmonary disease, very high loading conditions in the left, will really impact the stroke volume. Again, the architecture of the left side of the heart and the right side of the heart are different. And as they share the septum, we will see that septal involvement, whether it's an AMI with septal involvement, whether it's sarcoidosis with septal involvement, once you lose the septum and that excursion of the heart from both sides, from a valvular perspective, you'll see that these patients will have a lot of congestion, a lot of restriction, basically. And again, as we understand what we know from the sequence of events that happen, for example, in diseases that are well identified from a more chronic trajectory, like PAH, we know that that as we increase the afterload to the right side of the heart, there's all these adaptive mechanisms in which increase in the contractility eventually will try to compensate, and eventually, unfortunately, the right side of the heart, as we know, they don't have the same amount of muscle than the left. It will start to dilate, and that's when we see these very dilated hearts in pulmonary hypertension. Again, this sequence of events accelerate in particular illness like acute PE, RV, infarcts, and I will say in the heart failure space, LVAD, implantation early after LVAD right heart failure. So this concept of coupling the right ventricle to the pulmonary artery circulation becomes very important. Again, exemplified in many different disease states, like for example, after an LVAD, which again, this is an important concept that then has now been translated to what we talked about yesterday in terms of the use of transvalvular pumps that will have similar high flows in the LV, that can have the ability to change the septum or the architecture of the septum and the relationship between RV and LV. And again, if these ventricles are loaded with high congestive states, that they're high metabolic demands, whether it's oxygenation or pulmonary injury or congestion, the right heart will suffer. So importantly, as we talked about yesterday, RV related shock or RV related hemodynamics, very high loading conditions in the right and the left and biventricularly are associated with high mortality. And I think this slide sort of exemplifies all the complexity of issues that we were talking about beforehand, and really trying to understand if it's a problem with the ventricle, if it's a problem with the afterload, if it's a problem with the preload, becomes very important. That's why, as we were talking yesterday, the hour by hour on biventricular shock or right-sided shock and the right devices or right management of these patients becomes super important in trying to transition them. I think, again, hemometabolic cardiac shock really suggests right heart involvement. When you see very high pressures on the right side of the heart, as you can see here, RA pressure of 19, really almost the same as the PA diastolic, which again suggests that there's difficult feeling that from right to left, with low mean arterial pressure, on mechanical ventilation, inotropes, vasoactives, renal and hepatic injury that leads to high profile support that is biventricular, as we know with ECMO and Impella will support both sides of the heart. I think, again, once you start treating these patients in this particular situation, I think they will have the lowest possibility, at least based on our registry data, of associated native heart survival. So these patients going home with their own heart. So when we see these profiles, I think it's appropriate to consider replacement therapies evaluation, referral to a center that can allow to transition these patients to heart replacement, and I will say, particularly with hemometabolic biventricular shock, this is a patient that will require evaluation for both LVAD and transplant. Again, very high mortality. This is, as we were talking about yesterday, perhaps if you're starting a shock program, if you're starting a program for durable VATs, not the patients that you want to start with. And I think this is an important sort of message. And usually it will be, even if it's transient, that the right side of the heart is involved. So again, going from complexity and complex pathophysiology and more practical aspects, I think that the principles of identifying right heart shock is using appropriately a PA catheter. And a PA catheter, again, has the ability to profile right side failure, biventricular failure, and also, as we talked about, the afterload portion, okay? So the afterload portion being the pulmonary vasculature. And the pulmonary vasculature and our options to treat or, reduce the pulmonary vascular resistance, like pulmonary vasodilators, like unloading the left side of the heart, like treating any active pulmonary issues, will allow us to also take care of the right side of the heart. And again, this is just a basic infographic from a chapter that we recently did that pretty much these fellows from CardioNerds allow us to use the illustration for that chapter. And I think it's wonderful because it really goes through all the processes for identifying pulmonary hypertension that is secondary to left side disease, primary pulmonary hypertension, and the most important, perhaps, parameter to identify risk in right heart shock is the pulmonary artery pulsatility index. And again, from a very, very practical perspective, it's just the ability for us to show that this right side of the heart ventricle is able to pulsate a specific pressure and couple the amount of load that they have in the RV towards the pulmonary circulation. And again, for us, that number has been translated in our risk assessments for transitioning these patients to LVAD or transplant. Again, we talked about this. We find extreme value in profiling fully these patients with PA catheters. Again, from the perspective of the different hemodynamic measurements that, again, are all calculated once you arrange your electronic medical record systems and can be included as their derived measurements. Again, PAPI is PA systolic minus diastolic divided by RA pressure. You'll see that you'll start to have a more right side of the heart hemodynamic situational awareness in your center. And whether these patients are transitioned to remission, to recovery, or replacement therapies like LVAD, what we want to do is treat them so they are in this situation. Normal RA pressure, normal PA pulsatility, and again, if you estimate these PAPIs like in the 15s range. When do we get worried about an abnormal PAPI is when we start seeing less than 1.5, particularly for durable VAD, and I will say less than 2 creates concern. Again, these are dynamic measurements. They're not just one time, and we want to just plot them longitudinally. Decongestion is very important in these patients, avoiding how we talked about yesterday, hemometabolic shock, avoiding involvement from the liver and the kidney in right heart shock. Whether that defines right heart shock or that's a consequence of right heart shock is yet to be determined by your interventions. Of course, if we want to really, really tease out if it's a pump problem, if it's a volume issue, or if it's a pressure overload issue, again, high pulmonary pressures affecting the right side of the heart, I think the future will be to really profile these patients with pressure volume loops. Again, I don't think the field is yet adopting pressure volume loops throughout. One of the issues which I think needs to be resolved is the fact that they don't get adequately built upon versus the cost of the catheters. But I think it becomes a very valuable tool, particularly when you're trying to tease out whether this is a patient that is a candidate for VAD or these are patients that are candidate for transplant, or they require a more detailed pulmonary hypertension evaluation or a valvular evaluation. A lot of these patients having transmitted or translated their right-sided failure with regurgitant tricuspid, severe tricuspid regurgitation. So it's a frontier. When we talk about our algorithm, like yesterday, when we talk about right side support or biventricular support, becomes important to use the same language. As you can see, just to exemplify, our biventricular support is when we see high filling pressures in the right and in the left. The case that I just showed, there were high filling pressures predominantly in the right. Again, you will see a lot of patients that have BIV shock, that once you correct the left side of the heart problem, the right side of the heart will follow, and you will not need biventricular options. But again, it's important to understand that when somebody has BIV shock or right heart predominant shock, the message is that perhaps an intra-aortic balloon pump is not the right answer. And usually you will have to have either ECMO and a transvalvular pump, or two transvalvular pumps that, as you know, you have the option now to have them in an ambulatory setting, and I'm sure that's being shown in the stations outside. Again, multiple options for right-sided support. The one that is continuously the working horse is VA ECMO. VA ECMO drains directly the right side of the heart. You have other options like Protect Duo, which is a cannula that has 2 lumens and can drain from the RA and deliver in the PA. And now you have Impel RP that actually can truly have the same unloading mechanisms of the left side of the heart transvalvular pumps, and now in an ambulatory setting. So I guess the 3 platforms can be ambulatory under the right cannulation strategy for ECMO, and you have Protect Duo subclavian and RP up here. I think the question here is how are your lungs? If your lungs are not injured tremendously and you don't need an oxygenator, I think you can consider going straight to RP. However, again, with biventricular shock, this is usually a consequence of having both sides of the heart affected, a lot of congestion on the x-ray. Having vascular excellence, we talked about that, is very important. And I think when you start to see the combination of ECMO and a transvalvular pumps on the rise, I think that the problem of biventricular shock or right side of the heart involvement in shock, it becomes very evident. And as you can see, more and more patients are getting combination devices, whether it's VA ECMO with an intra-aortic balloon pump, whether it's VA ECMO with an Impella. So important to have these sort of educational sessions, to have these interdisciplinary team approaches, because once they're in that situation, the transition becomes complex. For us, submitted this to ESC, we wanted to see what's the associated survival of patients that have had, at a broad stroke perspective, ECMO alone, ECMO with Impella, and ECMO with a balloon pump. And in different phenotypes, we have seen that, ECMO with a transvalvular pump for LV venting in acute and chronic heart failure shock and in STEMI was associated with reduced survival. So a lot of this is being brought up, whether you do this preemptively, whether you wait, whether you need a trial to prove this. And again, this is just registry data, but again, give us a glimpse that perhaps in states of heavy injury of the heart or chronic injury in the heart, having an upfront strategy becomes important. These are multiple options that we were talking about, just from a more visual standpoint. All of them can be ambulatory from a percutaneous approach now, which is fantastic. You also have, and I'm sure our surgeons here will talk a little bit about also the possibility of supporting the right side of the heart surgically with CentriMac, which is always an option, particularly when you're in the OR or these patients are also undergoing a sternotomy or a cardiotomy. I'm not going to read all this stuff, but it's just important just to understand that we just have very limited data on the utilization of percutaneous right side support. None of these studies that have been published have shown more than 100 patients, and in fact, they're in the 10, 30, 60s at the most. So a lot of work to be done from a registry standpoint. We talk about this. Again, when I try to summarize the whole right heart failure, I think, and understanding the severity of right heart failure with deep phenoprofiling, clinical hemodynamic imaging, and think about preload, afterload, inotropic support, and you're still you still need a team, including the intensivist, the cardiac anesthesia, or anybody that can help reduce the metabolic demands with your ventilator, with your sedation, everything else that can reduce, again, metabolic demands. And again, if patients are still having hypotension, hypoxia, and organ dysfunction, really bring the interdisciplinary team to try to upgrade these patients to, Impel RP, Protect Duo, or Spectrum Cannula or CentuMac, which are the four options that we have. Decongestion, we talked about this at length yesterday. Again, this value of clinical hemodynamic and imaging perspective, transitions using transvalvular pumps, and again, I think from the rounding perspective, again, this will change a little bit more when we have the transvalvular pumps that are also ambulatory. But when we look at these patients, is trying to balance the flows from right and left side and really trying to focus on congestion. And again, that has been sort of the way we treat these patients, whether it's VA ECMO and 5.5 or RP and CP, is to focus on congestion to see if we can take the preload out of the equation, add an inotrope, add a pulmonary vasodilator, and see if we can get rid of that RVAD as soon as possible. And I think we have been successful with that strategy. Again, if it takes decongestion to bring the CVVH, renal replacement therapies, we do it. We're looking at 2, 3, 4 liters a day, not just like minus 100. So I think that's very important when you see these bi-V shocks that are on bilateral support, whether it's, again, VA ECMO and Impella or our PCP. And again, this is show, after effective decongestion, we have these patients on a very low performance level on the RP, 1 liter, and then with very good hemodynamic profile that allows us to just take these patients out of right side support, and that opens a whole new possibilities for these patients that were not perhaps eligible for transplant, like a durable VAD. Just to conclude, again, the spectrum of right heart failure is longitudinal. Restrictification in right heart failure requires integration of the clinical hemodynamic with a focus on RA pressure and PAPI and imaging. And I think profiling refractory cardiac shock really needs to create a question whether the right side of the heart is also failing. And in order to take care of these patients, you really require an interdisciplinary approach. Thank you.